Hello and welcome everybody to today's JSPS Pathology Grand Rounds lecture, sponsored by the Jean Shanks Foundation and the Pathological Society. As usual, if you have questions to ask the speaker, please can you enter these in the Q&A box at the bottom of your screen, and we will have a 15-minute Q&A session at the end of the lecture, and I will read out your questions then. Thank you. So it gives me great pleasure to introduce today's speaker, Judith A. Ferry. She graduated from Tulane University with a degree in chemical engineering after spending a year abroad in London at Imperial College. She earned her MD from New York University Medical Center. Judith was accepted as a resident in Anatomic Pathology at the Massachusetts General Hospital and stayed on at the MGH on faculty following her residency there. At present, she's the Director of Hematopathology and the first recipient of the Nancy Lee Harris MD Endowed Chair in Pathology at the Massachusetts General Hospital, and Professor of Pathology at Harvard Medical School. Her professional interests focus on general hematopathology, but especially on lymphomas involving extranodal sites. Judith is an author or co-author of over 150 peer-reviewed publications, including 2 textbooks, Atlas of Lymphoid Hyperplasia and Lymphoma and Extranodal Lymphomas. And she has contributed to the WHO Blue Book series of classification of tumours on the tumours of 11 different organ systems. Today it gives me great pleasure to introduce Judith Ferry, who will talk to us on space-associated lymphomas, a heterogeneous group of old and new entities. Thank you very much, Judith, and over to you.
Good afternoon to all of you, and thank you so much for that generous introduction. It's really such a pleasure to be able to join you, even if it's just over Zoom, and thank you so much for the invitation. So I would like to talk with you today about what I'm calling space-associated lymphomas. See how I can advance here. So we are not going to be talking about lymphomas arising in outer space. And for anyone who was expecting to hear about diagnosis of lymphoma in this particular vehicle, all I can do is extend my sincere apologies. Instead, we are going to be talking about lymphomas arising in anatomic spaces. And these include normal anatomic spaces that should be low volume potential spaces only, but that have expanded due to fluid or inflammation, for example, the pleural cavity, or abnormal spaces, such as within the lumen of a cyst or a pseudocyst. So let's start with pyothorax associated lymphoma. This was first described in English language literature in 1987. It is most commonly encountered in Japan. The patients who develop this are tuberculosis patients who have been treated with an artificial pneumothorax and who subsequently develop a pyothorax. They have no specific underlying immunodeficiency syndrome. Men are more affected than women, and there is a prolonged latency to the development of lymphoma from 10 to even more than 40 years. So patients are severely symptomatic as far as local chest pain, and they may have fever. The prognosis is poor, but they may respond to CHOP. Now, one hopes, though, that maybe this type of lymphoma will dwindle and not be seen anymore because patients are no longer treated in this way. But anyway, pyothorax-associated lymphoma is an EBV-positive diffuse large B-cell lymphoma with EBV type 3 latency. Typically, there's a large mass in the pleura in association with chronic suppurative inflammation. The lesion may be locally invasive, and it may also spread outside the thorax. The neoplastic cells may be centroblasts, immunoblasts, occasionally plasmablasts. They express pan-B-cell markers in the majority of cases, and typically there is a non-germinal center B-cell immunophenotype. CD30 is often positive. There is deletion of TNF AIP3 in a subset, which results in NF-kappa B activation, and there's also commonly encountered mutation of TP53. When a karyotype has been available, it is typically complex. And here is a radiograph from the upcoming WHO. And you can see that there's this side is normal. And then, of course, there's this big mass here associated with fluid, but the mass invading into the chest wall. And here also from the WHO, I've never actually seen a type of one of these types of lymphomas, but it looks like a diffuse large B-cell lymphoma, diffusely infiltrating and showing large atypical cells. So that's very rare. But it turns out that there's a set of lymphomas that are similar to pyothorax-associated lymphomas. And these are EBV positive diffuse large B-cell lymphomas arising in association with long-standing venous stasis ulcers, in conjunction with chronic osteomyelitis. Sometimes the patients have draining sinuses and pathologic fracture. And the interval to development of lymphoma in this group is also long, really, really quite prolonged. Most of these patients do not do that well. Most of them die of lymphoma, or if not of lymphoma, or of some other cause. So those who have studied this type of lymphoma have concluded that the features and the pathogenesis are similar to pyothorax-associated lymphoma, and a new category is suggested to encompass these lymphomas called diffuse large B-cell lymphoma with chronic inflammation. However, there's another group that shares some features with DLBCL with CI, but they lack chronic suppurative inflammation and mass lesions are absent. And these may occur in one of two general categories: foreign body associated, and that includes in association with metal implants in bones, in association with cardiac replacement valves, vascular grafts, surgical mesh implants, and even breast implants. Or they may arise in restricted spaces, such as within an atrial myxoma, within a cyst or a pseudocyst, there's a case in a hydrocele reported, rare cases in ovarian cystic teratomas, or within hematomas. So these so-called other diffuse large B-cell lymphomas with CI, typically, at least the cases characterized by arising in a cyst, the cysts are characterized by having a thick fibrous wall, there's patchy chronic inflammation, and dystrophic calcification. Now, the inflammation is often not even in continuity with the lymphoma, and there's no acute inflammation. The lymphoma does not form a mass. It is essentially always an incidental finding, and it is by definition localized. And what one sees microscopically are just a few little clusters of large atypical cells floating in fibrin and debris, or lined up along the inner wall of the cyst. And these cases are almost always EBV positive, and they are large B cells. They're often quite pleomorphic, and some of them may be plasmacytoid. They have a non-germinal center B cell immunophenotype, often with expression of CD30, proliferation index is high, and these also have an EBV latency type 3 with expression of EBNA2 and LNP1. Only a few cases have been studied, but this hypoxia inducible factor 1 alpha has been expressed by the neoplastic cells consistent with a hypoxic state, which makes sense, I guess, considering the closed space that they arise in. Treatment has been variable. In some cases, resection only has been performed. In others, patients have been treated relatively aggressively with Rituxan and combination chemotherapy, but the outcome has been excellent, and there have been no deaths attributable to these, which have taken on the name of fibrin-associated large B-cell lymphoma. There have been some cases, for example, in a big hematoma, where the whole thing wasn't resected. And then in that small subgroup, there has been persistence or recurrence. So here's an example of an older man who had a 9-centimeter retroperitoneal cyst. He had a section of small bowel resected to remove the cyst. So here's the bowel, it looks fine. But then there's a big cyst stuck on the outer aspect of the bowel, and it's got a thick fibrous wall with lymphoid aggregates in the wall. And then there's some fibrin and debris in the lumen. And when we look more closely, here we are again in that thick fibrous wall, patchy chronic inflammation in the wall, but then here there are large atypical cells within the lumen of the cyst. And on higher power, These are quite pleomorphic, really this very irregular nuclear contours, prominent nucleoli, but really just small clusters of cells in a background of debris. And my thought is that this very irregular nuclear contour that we see here in some of these cells, that seems to be a characteristic that's common in this type of lymphoma. It helps me recognize them anyway. And as far as immunophenotyping, here we have the tumor cells are CD20 positive, they're CD30 positive, and they're positive for MUM1, and then in situ hybridization for EBER is nicely positive. It's been hard to study the genetic features of this type of lymphoma because there are not many tumor cells, so sometimes the assays fail. But it does work out that there is clonal rearrangement of the immunoglobulin heavy chain gene. BCL2, BCL6, and MYC typically are not involved by translocations, although there have been rare cases in which BCL6 or MYC was rearranged. Also, extra copies of BCL6, MYC, and BCL2 have been described. Now, as far as more specific mutational analysis, we have a little bit of information. There was a case presented at the EAHP meeting in Edinburgh in 2018, and that case was EBV negative, so it's kind of the exception. And in that case, there was pathogenic mutations in PIM1 and in ETV6, and then that reference here for that. And then just in Florence in 2022, also at an EAHP meeting, next-gen sequencing showed frequent changes in immune surveillance pathway genes, histone and chromatin modification genes. P10 was common, which results in loss of NF-kappa B inhibition, and also JAK-STAT pathway genes were mutated. In some cases, there was an absence of TP53 mutation, so that sets this apart from pyothorax-associated lymphoma. So that's quite a lot of explosive information. And moving on, these other so-called DLBCLs with CI have pathologic overlap with classic diffuse large B-cell lymphoma with chronic inflammation, except that there's no mass lesion, there's no invasion of normal tissue, there's no suppurative inflammation. Patients are asymptomatic and they have a good prognosis. So maybe these lesions are immunologically isolated rather than associated specifically with inflammation. Maybe there's a failure of EBV-specific immune surveillance, and maybe a better term could be come up to set them apart from the more aggressive DLBCLs with CI. And here are some suggestions: fibrin-associated lymphoma, microscopic DLBCLs, fibrin-associated EBV-positive large B-cell lymphoma. Dr. Boyer from our institution has written, I think, the largest series of this type of lymphoma. And as far as nomenclature, back in the WHO in 2001, everything was diffuse large B-cell lymphoma. It was very easy. In 2008, the category of DLBCL with chronic inflammation was added. In 2017, there was a subset of the DLBCLs with CI, which was designated fibrin-associated diffuse large B-cell lymphoma. And then in the upcoming WHO, fibrin-associated large B-cell lymphoma is considered an entity to itself, separate from DLBCL with CI. The international consensus classification has retained the WHO 2017 nomenclature. And when I think about these two types of lymphomas, I think you can draw an analogy with Jupiter and its little moon Europa. DLBCL with CI is a lot like this huge planet of Jupiter, whereas fibrin-associated large B-cell lymphomas, which don't cause very much trouble at all, are much more like Europa. And I don't quite understand the angle that this picture is taken at, but supposedly this little black dot is the shadow of Europa on Jupiter. Now let's turn to breast implants and lymphoma. In 1997 was the first recognition of lymphoma arising in association with the breast implant. Most primary breast lymphomas are B-cell lymphomas. However, most implant-associated lymphomas are anaplastic large cell lymphomas. They're ALK negative, and these are T lineage lymphomas. And it doesn't matter whether this is cosmetic or cosmetic only or reconstruction after cancer. Doesn't matter whether the implants are saline or silicone, but these lymphomas can occur. So as far as some more specific information, the numbers on this are all over the place. I tried to pick the most reliable seeming ones, but there have been several hundred cases of breast implant associated lymphoma in the US and almost 1,000 reported worldwide. And it seems as though implants confer a 400-fold increased risk of anaplastic large cell lymphoma of the breast, and an individual woman would have a risk of 1 in 7,000. Whenever the type of implant has been known, it's had a textured surface, and greater than 90% are this allergen biocell textured implants. So this has been recalled. And now that this has been recalled, will breast implant associated anaplastic large cell lymphomas cease to exist? So as far as clinical findings, the interval from implant placement to lymphoma is approximately 9 to 10 years on average. There's a spread. They are unilateral in the vast majority of cases. Most women present with a late onset seroma. However, a minority can present with capsular contracture and discomfort. There is a minority that has a mass at presentation up to about 30%, usually less in most series. And then an even smaller proportion have regional lymphadenopathy. Rarely, just 1 to 3% of women have distant spread at presentation, and they tend not to have B symptoms. Those would be pretty uncommon. As far as pathologic features, the neoplastic cells are large and atypical, and they include cells with the classic appearance of hallmark cells. Usually, one sees small clusters of neoplastic cells in a background of debris. And typically they're found within fluid in the space between the implant and the capsule. And this type of lymphoma is called in situ breast implant ALCL or seroma breast implant ALCL. Now, a minority have a mass that has invaded through the capsule into the breast, and these are called tumor breast implant ALCL. As far as immunophenotype, the neoplastic cells are CD30 positive, ALK negative. They are positive for some, but often not all pan T cell markers. Usually CD43 and CD4 are expressed and CD8 is negative. CD3 is usually negative, and other pan T cell antigens can also be lost. MUM1 and EMA are usually expressed, and occasionally CD15 can be positive. So seroma ALCL has an excellent prognosis, but the prognosis is less good if you have a discrete mass with spread beyond the breast. So here's an example where the surgeon has done a wonderful job excising the implant capsule intact and taking out the basically curing the lymphoma by excision. And you can see that here what you have is on this side of the capsule, this would be where the breast tissue is. Then you have your thick capsule, and then somewhere in here is where the implant would have been. And within this fibrin and debris in this fluid that has separated the implant from the capsule, there are clusters, both large clusters and small clusters of large atypical cells. But notice that there's areas here where if you took sections where there's very little to no involvement by atypical cells. So it is possible to miss these lymphomas through sampling artifact. Now here's a high power, and we can see large atypical cells, and they are overlying an area of fibrosis with non-specific chronic inflammation. And here at a higher power, there's a little bit of refractile silicon here, which has been extruded from the implant and present in fibrin and fibrosis. And then these large atypical cells, including one that looks a lot like a Reed-Sternberg cell. And then on much higher power, here's the large atypical cells in a background of debris having the prominent nucleoli and one or two nuclei per cell. So a good way to make a diagnosis of this, which can work very well, is by aspiration of the fluid. And if you get a good sample like this, you find a lot of large atypical cells, mitotically active, and some of the cells can be even multinucleate. They have prominent nucleoli, such as you see here. And here on immunophenotyping, the tumor cells are negative for CD20. They are positive for CD4, CD43, EMA, and CD30, but they're negative for ALK. So as far as genetic features, this type of lymphoma has garnered a great deal of attention, both within the medical community and among patients. And so this has been studied quite intensely. And we do have more information about this type of lymphoma than we do about fibrin-associated large B-cell lymphomas. So the T-cell receptor genes are clonally rearranged. And there is no translocation involving ALK, TP63, or DUSP22. They're just not involved. Now, what you do have is commonly the JAK-STAT pathway is activated. And there have been a number of different mutations identified that have been associated with JAK-STAT pathway activation. But among the most common is this mutation of STAT3 with an S614R substitution, and of JAK1 with this G1097V. So those are recurrent, but there are others. There are also reported mutations of SOX1 and SOX3, both of which are negative regulators of the JAK-STAT pathway, so one gets activation. There's been a single case in which STAT3 JAK2 fusion was described, and this is by Quesada et al. From 2021. And no matter what the genetic change is, or even in those cases where no specific genetic abnormality was identified, if you do immunohistochemistry, the neoplastic cells are positive for phosphorylated STAT3, which indicates activation of the JAK-STAT pathway. So however they get there, they have JAK-STAT pathway activation. Now, more recently, investigators have found that epigenetic modifiers are altered in a majority of cases. So there have been loss of function mutations reported in KMT2C, KMT2D, TET2, and others. And for those cases with mutated KMT2C and KMT2D, there is loss of the protein correlate at the immunohistochemistry level, confirming that there has been loss of function or loss of expression. Now, this type of lymphoma also has something going on with the hypoxia pathway. So there's upregulation of the hypoxia signaling genes, and there's expression of carbonic anhydrase 9, showing that there's been some response to a presumably hypoxic environment. And then there have been alterations in the PI3K signaling pathway in a minority of cases. There have been a few cases with cell cycle alterations, including abnormalities of TP53 and others. It is common to have a complex karyotype. And then there's been a very interesting finding by copy number aberration studies. And it turns out that about 2/3 of cases show losses at 20q13. And this is an uncommon aberration. And so finding that here recurrently in the majority of cases of this type of lymphoma suggests that this really is sort of a unique anaplastic large cell lymphoma. We can speculate about the etiology and the pathogenesis of breast implant ALCL. Perhaps we start off with chronic antigenic stimulation of T cells related to the textured implant because of chronic friction with adjacent tissues. Some have suggested that there is a biofilm that develops that has bacterial contamination, sort of a low-level infection going on for a long time. Some have raised the question of the immunogenic properties of silicon, perhaps contributing to the pathogenesis. But perhaps following one of these initial insults, perhaps there is aberrant cytokine signaling, upregulation of hypoxia signaling genes, acquisition of mutations involving JAK-STAT pathway, or mutations of epigenetic modifiers or others, acquisition of cytogenetic abnormalities, and then with acquisition of independent growth with potential for spread. And one can conclude that breast implant ALCL is really pathogenetically distinct from other types of anaplastic large cell lymphoma. So, Southern Ring Nebula, it's kind of pretty. Now, let's turn to primary effusion lymphoma. And let's go back to the old days. When this type of lymphoma was called body cavity-based lymphoma, it was really very poorly understood. It was quite the mystery. So patients would come in with big serous effusions with large atypical cells floating in fluid, but without mass formation. And the patients affected were severely immunocompromised HIV positive individuals. The tumor cells typically were positive for CD45 and CD30, but B and T lineage specific markers were negative. And immunoglobulin heavy chain gene was clonally rearranged. So B lineage, but very mysterious exactly what was going on. So the first big breakthrough came in 1994 with the identification of herpes virus-like DNA sequences in AIDS-associated Kaposi sarcoma. And the authors from Columbia University identified unique DNA sequences in more than 90% of Kaposi sarcoma obtained from patients who had AIDS. And they concluded that these sequences defined a new human herpes virus, which they called Kaposi sarcoma-associated herpes virus. So that's good. That explains Kaposi sarcoma. That was a huge step forward. But the following year, some of those same authors also studied lymphoma. They looked at a large series of lymphoma, 193 lymphomas, some from AIDS patients, some not AIDS patients. And what they found was that new Kaposi sarcoma herpes virus, they found those sequences in 8 lymphomas in HIV positive individuals. All 8, and only those 8, were body cavity based lymphomas. That is, they had lymphomatous infusions. And all 8 lymphomas also contained EBV. And KSHV sequences were not found in any of the other lymphomas. So now we have kind of a specific marker for this type of so-called body cavity-based lymphoma. And it's taken on the name of primary effusion lymphoma, and by definition, it's positive for KSHV or HHV8, whichever you prefer. It is a rare lymphoma. It's only a small minority of all AIDS-related lymphomas, and probably less common now that we have better treatment for HIV infection. It presents as a serous effusion, usually without a contiguous mass. Pleural cavity is affected more often than the peritoneal cavity, which in turn is more common than pericardial. And usually only one body cavity is affected in a given patient. Most patients are HIV positive, and they are mostly young and middle-aged adults, but a small subset of patients are immunocompromised because of receiving an organ transplant or just because of the immunosenescence of aging. So these patients with primary effusion lymphoma commonly have systemic symptoms. They may have a separate solid or extracavitary, so-called solid PEL in a subset. Some of them have Kaposi sarcoma, no surprise, they're carrying the virus. Some of them have KSHV positive multicentric Castleman disease, no surprise, they're carrying the virus. And they have elevated KSHV/HHV8 viral load. Now, this type of virus and lymphoma is associated with high levels of VEGF, so you get vascular permeability and effusions where these tumor cells like to live. And I want to take just a moment to talk a bit about KSHV, or if you prefer HHV8. It is really an amazing virus. It is a large double-stranded it has a large double-stranded DNA genome. It's tethered to the host chromosome by the latent nuclear antigen, which is the immunohistochemical stain we use to identify it. And it has gene products that are really effective in evading the host immune response, promoting tumorigenesis, and inhibiting apoptosis. So really quite the oncogenic virus. Some of those gene products include viral IRF3, VFLIP, viral viral IL-6. It turns out that lytic replication of KSHV can be triggered by oxidative stress, by certain chemicals, by certain cytokines, and also by co-infection with agents such as HIV. So those who are HIV positive are really a setup, if they're already infected by KSHV, to develop one of the types of lymphoproliferative disorders that KSHV can cause. Interestingly, many of the viral genes have human homologs, for example, the viral IL-6. And dysregulated cytokine activation is common, which probably contributes to the systemic symptoms that these patients have. And HHV8 infection promotes hypoxia-inducible factor 1 alpha activity. So again, we have this hypoxia, and this maintains a metabolic state optimal for the growth of the neoplastic cells. So by definition, these lymphomas are positive for KSHV. The neoplastic cells can be anaplastic, immunoblastic, or plasmablastic by way of morphology. They are usually positive for CD45, CD30, EMA, CD138 commonly expressed, MUM1 also commonly expressed, but typically CD19, CD20, PAX5, and immunoglobulin, really the specific B cell markers, are negative. And what can really trip you up is there is aberrant expression of T cell antigens in some cases. This is especially a problem in the so-called solid or extracavitary PEL, which you have a mass lesion and it's expressing CD30 and it's expressing CD3. You think, oh, it's anaplastic large cell lymphoma. Well, step back, add a KSHV stain because it might be solid or extracavitary PEL. So EBV is present in the vast majority of cases, especially those that are individuals who are HIV positive. The EBV negative cases are more often encountered in elderly individuals who have no specific underlying immunodeficiency. So as far as the genetic and cytogenetic features, immunoglobulin genes are clonally rearranged and there's somatic hypermutation. There's no rearrangements of MYC, BCL2, or BCL6. There's no mutations of TP53. And you know what? You don't need any of this because in the vast majority of cases, you have, in addition to HHV8, you have EBVs. You have two powerful oncogenic viruses working together. And I think that's all you need to get a lymphoma. The cytogenetic analysis will typically show a complex karyotype. And the features genetically seem to correspond to a late stage in B cell differentiation, where there's loss of pan B cell markers, and there has been already a lot of somatic hypermutation. So here's an example. We saw this case actually in our regular in-house material just a few months ago. This was a 58-year-old man. He'd had a kidney transplant 21 years before. He was doing well, but then he developed a pericardial effusion. And he has kind of a cellular fluid here. He has his pericardial effusion was tapped. There's a lot of small lymphocytes and there's a few polys, but then there are these large atypical cells. And on high power, here are these large atypical cells with lobated nuclei, complex nuclear indentations, and we have some immunophenotyping that was performed on the cell block. So there's only rare CD20 positive cells, and the large cells are negative for CD20. Here's CD3, and CD3, I think the large cells are actually negative for CD3, and it's small cells that are positive. But here's CD30, and the large cells are definitely all positive for CD30. They are negative for EBER, they're positive for MUM1, and they're positive for HHV8. So our diagnosis here is primary effusion lymphoma, HHV8 positive, EBV negative, occurring post-transplant. And this is the nomenclature recommended by the new WHO classification. Using the WHO 2017 nomenclature and also the international consensus classification, one would call this monomorphic B lineage post-transplant lymphoproliferative disorder consistent with primary effusion lymphoma. All right, so we'll turn to a different topic. So this is the case of a 77-year-old man. He has a history, rather lengthy history of cardiovascular disease. He has arrhythmias, he has dilated cardiomyopathy, coronary artery disease, carotid artery disease, congestive heart failure. He also has chronic renal insufficiency and hepatitis. And on a background of all that, he comes in with a pleural effusion. He has no lymphadenopathy, he has no lung or pleural masses, his CBC is normal, and he has no history of malignancy, and he has no specific underlying immunodeficiency. And here's a cell block from his pleural fluid. And you can see there are numerous large atypical cells that have round nuclei, very prominent nucleoli. We have one binucleated cell, so quite atypical. And just for those who'd like to see this in a different color, here's the cytospin. We have uninucleate and trinucleated cells. So clearly something is wrong here, not a normal pleural fluid. And on immunophenotyping, those large atypical cells are CD20 positive. So right away, this doesn't seem to fit very well with primary effusion lymphoma, which should be negative for CD20. And only a few small T cells are admixed. Further immunophenotyping shows a non-germinal center B cell immunophenotype, CD10s negative, BCL6 positive, BCL2 positive, MUM1 positive. By PCR, there was clonal rearrangement of the immunoglobulin heavy chain gene, and fish showed no MYC rearrangement, but there were 3 copies of MYC. And I should say, most of the cells were positive for MYC, although some of them were just weak. The majority of cells are positive for Ki67, and then HHV8 was negative. So this is not primary effusion lymphoma, it's something else. So what do we call it? The nomenclature that's been introduced by the WHO for the next edition is fluid overload associated large B-cell lymphoma. The international consensus classification calls this HHV8 negative and EBV negative primary effusion-based lymphoma. It has also been known in the past, it's had all kinds of names, HHV8 negative effusion-based lymphoma, that was the prior WHO, HHV8 negative PEL, HHV8 unrelated PEL, and so on and so forth. In the WHO, the decision was made not to talk about what it was negative for, but what it was positively associated with. And this is kind of an opportunistic lymphoma that is able to arise in a place where there is an effusion. If there were no effusion, this lymphoma wouldn't be occurring there, is the theory. So that's how it gets its name. There is one difference between what the ICC accepts and the WHO accepts in this category, though. It's that the ICC requires the lymphomas to be EBV negative, while the WHO doesn't care whether they're EBV positive or negative. They'd rather include them because of the kind of distinctive clinical presentation. And these fluid overload large B-cell lymphomas mainly affect older adults, men slightly more often affected than women. Most of them lack specific underlying immunodeficiency except for advanced age. A small minority have been HIV positive. A few cases have occurred in iatrogenically immunosuppressed individuals, and rarely it's been reported in association with common variable immunodeficiency. So there are frequent risk factors for fluid overload are commonly found, including cardiac disease, hepatic disease, and then advanced age. And the pleural cavity is most often involved, followed by peritoneal cavity. In contrast to primary effusion lymphoma, multiple cavity involvement is not so uncommon, and then the pericardial cavity is least often involved. Pericardial involvement, when it's present, is often associated also with pleural cavity involvement. Now, a minority of these are associated with hepatitis C viral infection, and in this subset, it's typically the peritoneal cavity that is involved by the lymphoma. And then there's a small subset patients have hepatitis B virus. The outcome is better than that of HHV8 positive primary effusion lymphoma. It's worse in immunodeficient patients. And remarkably, there have been cases in which after the effusion is completely drained, patients go into a durable remission, having received no chemotherapy or anything. They just go into remission. It's really quite striking. And some of these patients have passed away, but often death is not related directly to the lymphoma, but rather to one of the underlying medical problems that these older patients have had. Now, as far as pathologic features, you have large atypical cells, centroblast, immunoblast. They can even be anaplastic. Some can have plasmacytoid features. In the majority of cases, the neoplastic cells have a non-germinal center B cell immunophenotype, but germinal center B cell immunophenotype is accepted, and it occurs in a minority of cases. EBV is usually negative. Less than about 30% of cases are positive, though. And EBV is more often positive in the setting of HIV infection or in those individuals who have had hepatitis C viral infection. So as far as genetic features, abnormalities of MYC are common. Translocations and amplifications are relatively common. Occasionally, there may be translocations of BCL2 or BCL6. There have been even rare cases of double hit lymphomas, fluid overload associated lymphomas reported. Karyotype is typically abnormal. Comparative genomic hybridization shows frequent copy number aberrations, and this is in line with what is typically seen in diffuse large B-cell lymphoma. No specific outstanding CGH abnormalities are described, as best I know. So as far as mutational analysis, those patients who have been of non-GCB or ABC type lymphomas have had mutations of MYD88, PIM1, BCL2, and the GCB subset has often had abnormalities of chromatin modifiers, CREB-P, KMT2D, and so on. And so this is kind of like DLBCL NOS, so not so different. And it turns out that these neoplastic cells have also had a fair amount of somatic hypermutation, and they correspond to a post-germinal center stage of B-cell maturation, but perhaps not quite as far from the germinal center as primary effusion lymphoma, which has lost all of its pan B-cell markers. Now, as far as the differential diagnosis of fluid overload associated large B-cell lymphoma, you'd think first of primary effusion lymphoma, but PEL is HHV8 positive and B antigens are negative. Importantly, HHV8 promotes the effusion. The effusion is not pre-existing, whereas fluid overload, the effusion comes first because of the patient's underlying medical problems. We can also consider in the differential pyothorax associated lymphoma, although that mostly doesn't happen anymore, but you'd look for a history of tuberculosis with pyothorax. You'd expect to see chronic suppurative inflammation and a mass, all of which would be, mass would exclude, and the other findings would be very unusual in fluid overload associated large B-cell lymphoma. But most important, you have to exclude secondary involvement of the body cavity by a primary lymphoma elsewhere. And in that, we rely on our clinical and radiographic colleagues to exclude that. So as far as risk factors, just to recap, PEL, the risk factors for primary effusion lymphoma include HHV8 infection, HIV infection, EBV infection, and also miscellaneous immunosuppression, as in the case that was seen at Mass General recently. The fluid overload associated large B-cell lymphoma, risk factors include advanced age, effusions for whatever reason that they're there, EBV and hepatitis C virus may contribute to the development of this type of lymphoma, and also miscellaneous immunosuppression, but usually advanced age. So what overarching conclusions can we draw? We have talked about a quintet, not of galaxies, but of lymphomas. So these space-associated lymphomas have overlapping cytomorphology. Here we have again, pyothorax-associated large B-cell lymphoma, fibrin-associated large B-cell lymphoma, primary effusion lymphoma, fluid overload-associated large B-cell lymphoma, and breast implant ALCL, sorry. And just to summarize, five rare lymphomas arising in spaces and composed of large transformed lymphoid cells, DLBCL with CI, CD20 positive, EBV positive, HHV8 negative, non-germinal center B-cell lymphoma with a poor prognosis, fibrin-associated large B-cell lymphoma, similar immunophenotype, but with an excellent prognosis, breast implant-associated ALCL, CD30 positive, ALK negative, T lineage lymphoma with an excellent prognosis in the absence of a mass or invasion. And then primary effusion lymphoma, HHV8 positive, B antigen negative with a poor prognosis, fluid overload associated large B-cell lymphoma, HHV8 negative, typically CD20 positive, non-germinal center B-cell lymphoma with an intermediate prognosis. As far as pathogenesis, one or more of these may be active in each of the lymphomas in this group, including chronic antigenic stimulation, systemic immunosuppression, immune escape or local immune dysregulation, hypoxic microenvironment with protective response by tumor cells, and then specific viral associations and genetic changes. And these do vary among the different lymphomas. So we're going to have to say goodbye to space now and return to Earth. Last look at the night sky. And this is my neighborhood. And just off to the left is where Massachusetts General Hospital is. So it's really great. I can walk to work. And I don't just do hematopathology. I also wrote a novel. So worked pretty hard on this. But that's it. And if I can try to answer any questions, I will be happy to do so.
Okay, thank you very much indeed, Judith. That was a really interesting, excellent lecture. I thoroughly enjoyed that. And can I say how clearly you explain these rare and very interesting lymphomas. Thank you so much. Now, can I remind the audience, if you do have questions, please put your questions in the Q&A box at the bottom of your screen. I'd like to start off with the first question, if I may, Judith.
Yes.
Can I take you back to your description of the breast implant ALCL, where you talked about the copy number aberration in 2/3 of cases on 20Q13.13? Has anybody searched that region for genes of interest, and are there any particularly interesting candidates in that region of the genome?
I don't think that's been elucidated. That's a really important question, and I'm sure that the authors who wrote that paper are working on that now, but I don't have a good answer to that, sorry.
Okay, thank you for that. I'm going to go to the Q&A box. The first couple of questions are from Kaushik Das Gupta. He asked, does BI-associated ALCL fall into this group? Not quite sure which group he's referring to. And his other question is, have you seen these in adrenal cysts? Thanks.
Let's see. So, sorry, but the first part, breast implant associated ALCL?
Yeah, I don't know what that
okay.
question means. He doesn't specify which group he's talking about when he says this group. So I think we'll move swiftly on to his second question.
Okay. So I'm trying to remember. I mean, they certainly could occur. The fibrin associated large B-cell lymphomas can certainly could occur in an adrenal pseudocyst. I don't specifically recall whether it's been reported. And one thing that's kind of interesting, as long as Dr. Gupta mentioned breast implant ALCL, it's interesting that you can get fibrin associated large B-cell lymphomas and sort of on the border with diffuse large B-cell lymphomas with chronic inflammation associated with breast implants. So the only lymphomas that arise in association with breast implants are not ALCLs. We actually have some of the EBV positive B-cell lymphomas arising, but less commonly in that setting. And there are some clinical and pathological differences there as well.
Okay, thank you. So we have a series of questions from your good friend and collaborator, Sarah Coupland. I'll take these one at a time, if I may. So Sarah says, very interesting presentation, wonderful images, thank you. With the breast implant associated lymphomas, you mentioned that these were associated with the Allergan implants mainly. Were there other types of implants also associated with this disease? Are these implants now banned worldwide?
I presume that it must sporadically arise with some other types of implants, but the Allergan was the only one that really that I read that had been banned, and presumably but all of the ones where the surface has been reported, all of those have been textured. So I would imagine that even if there wasn't a specific ban, that surgeons would no longer choose to use an implant with a textured surface, and they go with a smooth surface implant. And so for the 10% that perhaps were not associated with the allergen implant, maybe they were still textured, and those won't be used anymore. So I suspect this disease will go out of existence.
Okay, thank you. So Sarah then asks, is there an association as to why the space and fluid associated lymphomas are linked often, but not always, to viruses?
Yeah, that's also a good question. I mean, it's interesting because the anaplastic large cell ones are not, but the majority of the other ones, well, not the fluid overload associated, but the other ones often do have EBV especially, and then of course HHV8 for primary effusion lymphoma. I think it may be something, especially with EBV, if you leave EBV unsupervised, it will do bad things to your B cells. And before you know it, you have a lymphoma. If you have a B cell just kind of sitting in a cyst and it's EBV negative, it's probably not going to do anything. But if EBV is there and EBV has immortalized the cell and kind of it's a little bit irritated by something or another, EBV is going to just cause problems. And yeah, blame it on EBV.
Okay, thank you. So moving on to a question from Zbigniew Rudzki. Is there any role for OCT2 as a B cell marker in those which have the nearly null B cell phenotype?
So for example, in the primary effusion lymphoma, I would think that as far as OCT2, I don't know that that's been extensively studied, but I would expect it to be negative in primary effusion lymphoma because it doesn't express other B cell markers and it doesn't express immunoglobulin in the vast majority of cases. Rare cases have been described. So I would expect that OCT2 would probably be negative. So I wouldn't count on it. I think what you really want is you want your HHV8 stain, and if that's positive, then you know it's a B lineage lymphoma.
Okay, thank you. So Richard Byers asks, are the patients with breast implant associated ALCL risk associated breast implants being followed up by mammography given the 1 in 7,000 risk?
Well, women who are, I mean, they're all adults, and women over, I guess it's 45, are meant to get mammograms regularly anyway. So yes, I would say yes, and they should be, and I'm sure that extra attention is paid to the ladies who have had who have implants. But the thing is, with the breast implant associated ALCLs, usually the patients are symptomatic, so you probably wouldn't really. I mean, they should be getting mammograms, but the patients are symptomatic. I mean, they have swelling of the breast. You know, the fluid collects, and the breasts are asymmetrical. And so presumably in most cases, it's symptoms that bring the patient in to see her doctor. Not I don't, theoretically they should be getting mammography, but I don't think these are routinely picked up on screening mammography.
Okay, thank you. So Richard also asks, why do you think the BI ALCL is a T cell lymphoma versus the rest of the space associated lymphomas being B cell lymphomas?
Yeah, that's a really good question. And thinking about that a bit, ALCL is a heterogeneous disease. We have, of course, ALK positive ALCL, we have ALK negative ALCL, and then we have this category of cutaneous ALCL, all with different risk factors. I do know that ALCL of one type or another sometimes arises in an unusual clinical pathologic setting. For example, years ago, there was a paper about ALK positive ALCL, I think, arising in association with insect bites. So really bad insect bites, kind of super infected and stuff. And then rarely patients develop ALCL. So with this cytokine sort of thing going on, I suppose that one of the lymphomas that can develop is ALCL. We've also seen, and others have rarely seen, both ALK positive and ALK negative anaplastic large cell lymphoma arising in individuals who have had chronic lymphocytic leukemia. So why that's happening, who knows? But there seems to be some crosstalk between CLL cells and T cells, sometimes leading to T cell exhaustion or some other abnormality in T cells. And then in rare cases, you can get a T cell lymphoma. Among the more common types is ALCL, arising in CLL patients. And these are including some cases of ALK positive, which those shouldn't be arising in people who are old enough to have CLL. So, ALCL also arises after CLL. It's strange, so that we don't know everything about ALCL, and it can crop up in uncommon circumstances. So I think that, the insect bites and in association with CLL, and now we have this association with breast implants. So yeah, I think there's maybe more about the immunology of this than we know so far.
Okay, yes, thank you. So another question from Sarah Coupland. Is there any association of these space lymphomas with autoimmune diseases? If so, which ones?
I'm not aware of any association of the autoimmune disease itself with these lymphomas. If patients were treated with disease-modifying therapy and were somewhat iatrogenically immunosuppressed, then I suppose they could be at risk for say the fluid overload associated, or could, because immunodeficiency underlies that. But I don't recall any cases reported of individuals with autoimmune disease who've developed a space-associated lymphoma.
Okay, thank you. So moving on to a question from Rifat Hamoudi. He says, you mentioned that some of the lymphomas have small numbers of cells. Have you tried to use laser capture microdissection and tried to characterize their genomic profile to see if they have unique signatures?
Well, that's a very good question, and it's a source of some frustration, because I actually have some unstained slides from a number of these cases, and I've set it off for genetic analysis, and allegedly, it's been there with these guys for a long time. Allegedly, there is some kind of analysis in progress, but I'm looking to see. I think Dr. Boyer's paper, where he talked about the groups of genes that are modified in these fibrin-associated large B-cell lymphomas, that will be a step forward. And I think that's the group of lymphomas that really could benefit from more study.
Okay, thank you. So moving on to two questions from Simon Rajendran. Simon asks, why is EBV LMP1 negative in primary effusion lymphoma, and do you routinely use flow cytometry for breast implant seromas suspicious for lymphoma?
Okay, wait a minute. So let's see. So why is LMP1 negative in primary effusion lymphoma? Yeah. I mean, I don't know. LMP1 seems to go along, like in the way I have to remember things, that LMP1, I mean, we get it with post-transplant lymphomas. We get it with lymphomas that have tumor cells that are Reed-Sternberg cells or look like Reed-Sternberg cells. And I guess even in infectious mono, you can have a little bit of LMP1 on some of the Reed-Sternberg-like cells. Why it's not expressed in PEL, I am not sure of the mechanism behind that. I mean, PTLD patients usually have type 3 latency. So certainly they're very immunosuppressed, the PEL patients. I'm not sure. And then I'm sorry, the second question?
His second question is, do you routinely use flow cytometry for breast implant seromas suspicious for lymphoma?
We encounter those cases only really rarely. And so, geez, it's been so rare. We probably, if we thought we were going to get a sample, we probably would try. Although in our laboratory, we haven't had a lot of luck with large lymphoid cells. So I don't recall a case where it's worked. And it's so easy to just make a cell block and then just do paraffin section immuno. That seems like that would be quite adequate. And yeah, I don't ever remember a case, breast implant or otherwise, where we've successfully immunophenotyped an anaplastic large cell lymphoma by flow.
Thank you for that. Now we've just hit 3 p.m. and so that's the full hour, and we've had a very active and full Q&A session. We have a tradition of finishing on time, so I'm going to call a halt to the proceedings there. And I'd just like to finish off by thanking you, Judith, for a really fantastic talk, very interesting talk, clearly stimulated a lot of interesting questions. So thank you very much indeed.
Okay, thank you very much. It was such a pleasure. Really appreciate it.
Thank you, and that's it. We shall sign off now.
Okay, bye-bye.
Thank you. Bye-bye.
Bye.